be facilitating today and moderating the panel. And helping me is Tenzor, who'll keep an eye on the chat box, and Mary is taking some notes. I'm really honoured to have been asked by HelpAge to help with this webinar. They've been able to implement some really outstanding work in very difficult circumstances, and I'm so pleased that they have this space to share their experiences, and also grateful to everyone who has attended, who has agreed to speak on the panel. I really hope it's a useful learning experience for everyone. Before we move on to the agenda, just a couple of housekeeping rules. Nothing out of the ordinary. If you're not talking, please keep yourself on mute. And I think with the camera off, this will reduce any background noise or distraction for the presenters. Please feel free to turn the camera on if you're discussing or you want to raise a question. We have time at the end of the meeting for Q&A, and that can be questions to both the presenters and the panelists. So we'll hold off on questions until then. If you want to type a question in the chat, you can do so at any time, and we'll keep a note of that. And if you want to ask a question to a particular person, presenter, panelist, or so on, then please just flag that in your chat message as well. Of course, if you'd rather speak directly, then please just throw up your hand and we'll try and come to you during the question and answer section of the webinar. So the focus of our webinar today is on digital adaptation in the health and care sector, and the unique circumstances in Myanmar during the SUNI-SEA project really expedited our journey in this direction. But it's a really critical topic as digital healthcare tools and advances continue to grow and revolutionize the way we provide and receive healthcare. And of course, it's a really wide topic. And today our presenters are focusing on their unique experiences in the work they've been doing in Myanmar under the SUNI-SEA project. And our panel will be able to engage with the topic a little more widely, but still within their sort of specific fields of interest and experiences. So our agenda today is a presentation from the project team. Professor Oren will present on the development of our online learning platform, and Dr. Khin and Paing will share their experiences with the self-care application. Then we'll follow this with some panel discussions. And following the panel, we'll have 20 minutes for questions, as I've mentioned. So I'll just begin by introducing the presenters. Later, I will introduce our panelists as well. So Professor Oren is the rector at the University of Public Health in Yangon. She's a medical doctor with decades of experience in public health, with a particular focus on NCD, health promotion, health economics, and is very much interested in collaborative research and has been an integral part of the SUNI-SEA project team. Dr. Khin is a medical doctor and an expert in public health and is currently working as the SUNI-SEA project manager. She's over 10 years of experience in project implementation and management in Myanmar, with experience in both non-communicable disease and communicable disease work. And Paing has been working as project officer at SUNI-SEA and the SUNI-SEA Myanmar team, and working very closely with our intergenerational self-help clubs, inclusive self-help clubs, sorry, and has over 10 years of experience. So without any more chit chat from me, I will pass over to Professor Oren to begin the presentation. Thank you.
Hi, everyone. Good morning, good afternoon, based on where you are. Thank you all for being here today. I'm Professor Oren, head of the consultant team of SUNI-SEA Myanmar. Let me start my presentation. Knowledge and care in your hands by digital adaptation for the community level management of NCDs. Here a look at the brief background of circumstances demanding the involvement of technology. SUNI-SEA project focused on the scaling up of effective intervention for the prevention and management of NCDs. It started since 2019. Key project interventions are as follows: train basic health staff to develop expertise in NCD, to build the skills of volunteers, to conduct health screening for community members, to identify NCD risk factors and refer people with risks to health facility, to conduct health promotion events, to increase awareness about healthy lifestyle and strengthen self-care practices. Previously, we planned to implement project activities in selected field areas, train primary healthcare providers and ISHE members in person, and conduct door-to-door risk factors training by ISHE members. But as you all know, we faced difficult situation of 2 Cs, COVID and the coup. Based on these situations, security is the main concern for us. Protecting the safety of project communities and project team is our priority, while ensuring the continuity of project where possible. Next, please. To continue program implementation in challenging times, our team practiced teleworking, maintaining close contacts with partners by several and repeated video conferences, revised the project plan, and finally changing implementation methodologies. We concerned all perspectives and decided fieldwork is not possible at that time. So, in-person training for primary healthcare provider was adapted to online learning platform. Next slide, please. So, in-person training for primary healthcare provider was adapted to online learning platform for NCD public health modules and community level NCD screening, health promotion and referral to health facilities work, adapted to digital self-assessment and health education application for screening of NCDs and mental health by using HIS2 tracker software. Next, you can clearly see the drivers and process of adaptation in this slide. Now, let me briefly talk about the role of digital technologies in improving healthcare for people with NCDs. Here we can see the different benefits for 3 different sectors, such as prevention, diagnosis and treatment, and follow-up. Digital technologies enhance customized preventive interventions and improved speed and efficiency of diagnosis, better continuity of care, and enabling patient engagement. Let me move on next slide. And the next. Online education is inclusive and creates the education for all. So please let me bring some quotations about online education here. CEO of the ETX, Annette Agarwal said, online education is like a rising tide. It's going to lift all boats. Another famous author, Donna A. Abernathy, said, online learning is not the next big thing. It is the non-big thing. I hope you all agree with these sayings. The next slide. The current slide is reflecting not only the timeline and the progress, but also the effort we made and the hardship we went through and the achievement we attained. Starting from January 2022, we developed modules, adaptation of modules content into platform, translation to Burmese language, pilot testing the learning platform, and finally, we conduct the webinar to present our product right now. I'd like to continue brief description of modules. The target learners are frontline workers who are working at the public health field, such as mainly working at the primary healthcare setting, such as rural health center, close proximity to community. So CBO, CSO, or NGOs. And the background education for them are any graduate not having specialized degree concerning public health. The objectives of the developing these NCD modules are as follows. To improve the capacity of frontline public health workers in prevention, management, and control of NCDs. To improve the participants' understanding on the basic concepts of NCDs within public health approaches. To familiarize participants on community-based interventions for prevention and control of NCDs. Now, I think we are ready to look at the contents of modules and the relevant methodologies we will use in teaching them. There are altogether 7 modules, such as Introduction to Public Health, Introduction to NCDs, Comprehensive Assessment and Problem Identification, Prevention and Control of NCDs, implementation of interventions, monitoring and evaluation, and finally, introduction of NCD self-care. Learning objectives and content in detail will be presented in coming slides. This slide shows learning objectives and contents of Module 1 and 2. Next. This is for Module 3 and 4. And the next, this for 5 and 6. And the final one is for Module 7. Next slide. We used whiteboard animation and recorded PowerPoint for more visualization and comprehension of contents. Considering with assessment, we were doing both objective questions and subjective questions as discussion forum. This is an example of objective assessment, single best answer for Module 3. And another one is the discussion forum for Module 6. The participants will be required to pass the section of quizzes or discussion forum at the end of each module. With the exception of Module 1, it is only video animation. Participants must score a minimum of 80% in order to progress to the next module. Additional resources are provided in each of the modules to read and reference for the participants. Now, I'd like to continue to present challenges we faced during the process. Every activity has challenges to succeed. Personally, I take the challenges as the windows to success, and as we have expected, we can see some challenges to overcome. I'm sure we are confident in dealing with these challenges and happy for the lessons we've learned. We faced challenges in all phases. During the development phase, one of the significant challenges faced by the team was communication and collaboration with web developers. Even though the team had to conduct many time-consuming discussion rounds with developers, there was some communication gaps and similar technical issues that had been discussed at the previous meeting were still unresolved and occurred at the next meeting. That resulted in another challenge, testing and revision iteratively. The challenges during pilot testing were slow loading of video presentations due to internet connectivity and navigation difficulties due to LMS-related technical issues. Another challenge was adapting to different learning styles, as few participants might be unfamiliar with online learning. In addition to these challenges, the important one for long run, scaling up and sustainability challenges are being faced. Those are security and privacy concern for storage of personal data of the users, hosting fees, maintenance for this online learning process to be promoted and active, and technical support for being the interactive course and engagement of participants. Another challenge is difficulty in monitoring progress. It may be challenging to track learner progress and assess the effectiveness of online learning modules. Next, please. As we need to hear from learners, the pilot testing of online learning platform was carried out from 6 to 9 March 2023. 12 participants from a variety of community-based organizations were included in this testing. The quantitative findings regarding the perception of participants on usage of online learning platform and contents of NCD public health modules were assessed using 5-point Likert scale. 1 not very happy to 5 completely satisfied. You can clearly see in the graph, there was no item that was rated below 3. According to the figure, the main rating scores of all items were around 4. It means all are satisfied. The item regarding satisfaction or opportunities for engagement with other learners had lowest mean rating score, 3.88, and the item with the second lowest mean rating score, 4, was perception or easy to use and navigate the online learning platform. These indicate user interface issues. Next, please. To support the quantitative findings, we also conducted qualitative case studies by interviewing 4 participants to gain their insights into perspectives and experiences regarding the contents of NCT Public Health module and online platform usage. The interviewee raised the user interface issues that some of the participants had faced difficulty in using discussion forum, such as not appearing the explanation for discussion topic after posting the discussion points by the user. obtaining the certificate without having completed the whole set of modules, error in grading systems. All 4 participants highlighted the internet connection issues that they had faced, the frequent interruptions in loading videos. Regarding the contents of the modules, one participant responded that the training would be better if more quizzes were included. They also pointed out the incorrect spelling in the contents in Myanmar version. The participants perceived that this NCT public health module is useful for themselves as well as their organizations because they gained new knowledge about NCT and related issues that will be practically applied, and they would like to share their knowledge as well as about this training to their colleagues. They also perceived the module's contents are interesting and suitable for slow learners. They suggested, in order to improve this online learning module, that the platform should be promoted with the help of other organizations, and a mobile version should be developed and more courses in Myanmar language focusing on certain NCDs such as hypertension should be developed. Next, please. I'm sure we are confident in dealing with these challenges and happy for the lessons we've learned. We've deeply concerned the importance of communicate clearly with web developer to get what we want to be in LMS. Interactive and attractive LMS is really valuable for learners, but it is more time-consuming and expensive, so we need to plan more budget ahead. We have translated the contents to Myanmar language. It favors the user-friendliness from linguistic aspect. Next, please. Finally, we corrected errors and updated the learning platform according to the feedback and suggestion from users. Now you can visit at the link and enjoy the module if you are interested. Next, please. The next, please. And this slide shows the plans that the team intends to proceed. Scaling up goal to have staff who are able to dedicate time to interact with participants on the platform and keep discussion forums lively and engaging. Expand the range of modules. There is a need for a wide range of modules on NCT prevention and control, covering different risk factors and populations. Further efforts may focus on developing additional modules and incorporating other training contents to address these gaps. Improve accessibility and reach. Efforts should be made to improve the accessibility and reach of the modules. These efforts involve further rolling out, developing mobile-friendly version, and promoting the modules through social media and other channels. And the final one is maintain and update the modules. To ensure that the modules remain up to date and effective, it is important to maintain and update the content regularly. This could involve incorporating new research findings, updating statistics, and refreshing the examples used in the modules. Thank you so much for your attention. I'm sure we all feel the integration of digital technology in healthcare is very promising and encouraging for all of us. Thank you again. Over to you, Poppy.
Thank you, Professor Oren. That was a really interesting quick overview of the work you've been doing on developing that online learning platform. And it was great to hear some of the feedback from people piloting it as well. I think next we'll move straight into the presentation from Dr. Khin, and we will save all our questions for you and for others to the end. So thank you, Dr. Khin, over to you.
Thank you, Poppy, for your invitations. So good morning and good afternoon, everyone. So let me move on to another digital approach that we developed under the SUNI-SEA project, that is the digital self-care. So for the digital self-care approach, we use the basis of the data science to tracker software. That is the most commonly used health management information systems, and also the most of the countries they use DHIS2 software mostly in the NGO-based programs, and also that DHIS2 tracker application is tracking of the individual, can track the individual health status over time, and also this application can be the potential links to the community generated data into the national HMIF system in the future. So our team decided to choose DHIS2 trackers to be put it as the self-care, focusing on the risk of having NCDs and also the mental health. That is the essentials and the popular topics in the Myanmar populations. So for the next, because of the challenging situations, both issues like the COVID and also the safety and the security issue, we also need to adapt our project activities into in-person. Previously, we planned to do in-person screening approach into the digital self-care approach. So we have a continuous consultation with the local and international experts and also the key stakeholders for developing these self-care applications. And then we developed these applications, and then after developing this application, we also testing like a preliminary testings among our community volunteers at the Shan state for these applications. Based on the results of the preliminary testing and also the feedback collected, we also adapted applications. And then for the implementations and the promotings of this digital self-care, we also training to the community volunteers to provide support to the communities to use these applications, and then encourage and the support for the how to use this application properly among the communities, because this is the first time self-care application among the community. So we need to be the support to the community via the volunteers. So we train the volunteers, not only focusing on the using of this application, we also train the volunteer about the knowledge of the NCDs and also the mental health. And also for the, we suppose the volunteers to train how to using of the physical measurement tools, such as the blood pressures, weighing machines, and measuring tapes, that can help to the community to make the measurements of the physical measurements that was need to put it in the application for their risk factors assessments. So along with the trainees, we also developed it and then provide the volunteers, such as the volunteer manuals, user guidebook for the self-care applications, and also the promoting mental health book that can have the volunteers to the communities. And also we developed the pamphlets, demonstration video, such as like a step-by-step using of this digital self-care, and also the user guidebooks distributed to the communities. So in this, under our projects, we also provide the training like a psychological first aid among the volunteer to help the community if there is any crisis or the situations happen in their community. So this is the training part that we provided and as our SUNI-SEA project for the self-care applications. So after the bidding for the capacity among the volunteer, we also promoted this self-care application among the 56 villages at the Shan State, and also the 80 inclusive self-help group situated villages at Yangon, Mandalay, and the Iawari regions. In here, I would like to mention is the community we target is the general population, 56 village, and also the inclusive self-help groups that is mainly found with the older people and people with disabilities, and also included with the younger generation in that groups. So we can, our target population is like the general communities and also for the older people. So this is our implementation areas and the target groups. So we implement and promote these applications not only on this area, but also we also promote this application via the Older People Federation. So the Older People Federation is a kind of the big representatives of the older people in the Myanmar. So mostly found with the older people. So we promoted these applications into the older people conference. So most of the older people and the ISAG group in the whole country know about these applications and that they can use in their own ISAG and in their community. So this is the promoting way we can we did it during our implementation times. On this periods of time, we also regularly check and monitor our application data quarterly basis. So every time we just aggregate the data and then checking whether there will be the server functions and also the how many patient enrollments and such a kinds of indicator we have. So we also monitor this kinds of the disaggregated data along the time. And then we have continuous monitoring by our project officers to use this application, whether that is a really function or not, is there any difficult phase, and then we collect the many case studies and then focus group discussions and then gather the feedback along the periods of our implementations. So I would like to move on to another side. So you can see, you can easily download our subcare application from the Google Play Stores and then easily check your risk of NCD and the mental health risk factors. So in this application, we also included the subcare questionnaire, especially for the risk factors of NCDs and also the film risk assessments and cardiovascular risk scores and also the body mass index you can access from these applications. And we also integrated as a physical measurement can access in these applications. And so to be the more convenience for our communities and our implementation areas, we support the like a physical measurement tools such as the blood pressure machine, weighting machines, and the measuring days. And they are our implementation areas at the community. So the people can use this measurement tools and they feed it their results for their measurements and then get the risk levels of via this application. And then in this application, we integrated the mental health part. We focus on the three main most popular mental health problems, such as the anxiety, depressions, and the post-traumatic stress disorder. So we included these kinds of the screening included in the applications. And apart from the screening part, we also included the counselings and the health promoting sessions in the application. So the user can easily get the health information based on their risk levels and also for the get knowledge from these applications. So this is some of the dashboard data that we developed, we collected during this implementation periods. So in this slide, we just took off some of the screenshot data during our implementation periods. So the data we have disaggregated data such as the age group, sex, and also the locations. So then I would like to share some of the key reflections that we got, such as the women are the more likely to have nutritional risk factors, and also the men is the more likely to use tobaccos and tobacco products, which are really useful because that allows us to think about the tailorings of our health messages. So apart from the screening tools, we also expect using this application among the communities. This application data are the really significant improvement in the HelpAge international data collection availabilities with the benefits of this program. So for the next part of the slides, may I invite the non-mobile to share the feedback from the community for subcare application. So mobile, could you please present? Thank you.
Thank you, Dr. K, for your invitation. Now I would like to share some feedback from our ISAG and community while they use our application. The first feedback from our community member, he said it benefits a lot as our villagers have less knowledge. They do not know how to take care. With practical words, people come to know what is do and what is don't. Older people gain health knowledge and they could take care of each other. And another feedback from our ISAG volunteer, she said, we are not doctor or health personnel, but we can easily do the screening and monitoring the progress or status of hypertension, diabetes, and mental health problem. And another feedback from our ISAG volunteer, she said when she introduced him with the application and advised what was suggested on the application, going to clinics, hospital as much as he can, and then he go to clinics hospital regularly. The next one. Another feedback from our ISAG leader, he said, before I smoke and chew bitter, now no more smoking and chew bitter. Besides, I take care of my health. I eat healthy and nutritious food. That is why I am a good health. These are the benefits of SUNI-SEA project. And another one, feedback from our ISAG volunteer. She said, I gained a lot of health knowledge once I started using the application, and I continue to use the application to have a regular checkup. And next, please. Okay, the last feedback from our volunteer. He said repeat use of application is very beneficial for them, but our most targeted age population is around 60-year-old who have difficulty in reading and looking at the letter or phone screen and a user touch screen, mobile handsets. It will be good if someone in the family could help them with this. Ever thought they could be forgetful, they could rehear from the family and be a soft reminder, provided the written or printed ones would be better for those who do not use mobile phone. That is all of my side. Thank you, Dr. K. Open to you.
Yes, thank you, Mubai, for your very interesting feedback from our application user. So let me continue the presentation and then summarize the feedback that we collected during our focus group discussions, case studies, and also the key informant interviews among our community volunteers, community members, and also the ISAG groups. So in here, mainly is the users at the application aspect. This application is only using for the Google Android. So they doesn't work in the iPhone, and then some of the tiny phone without Play Store, Google Play Store cannot use, and also some of the older people has a poor digital literacy. So that also be the one of the challenge and also the feedback from the communities. And also there will be also the limited using of the phones among the older people. And another thing is the internet issue. Yes, surely we still have a difficulty to get the internet accessing, especially in the hilly regions and also the rural areas. So even though this application can use offline and the assessing of their health risk, but they also need to be the internet at the times of the installing this application, and also the data synchronization process at the time need the internet. So internet connection issue is one of the feedbacks that we got as a challenge also. So for the opinions we got is they also preference to be the screen with the help of the volunteer manually from the community. They also would like to get the help from the volunteer using the manually. They prefer more, but they also comfortable to using this application with the support of the physical measurement tool that will really helpful for them. And also this application is really useful for the early assessing of NCDs and mental health by using this application. So this is the that feedback that we got. And also another suggestion that we got is that there should be the accessible for the different types of the forms. So this is the summaries of the feedback from the communities. And then let me move on to the challenges part. So yeah, we also still need the internet accessibility is the main challenging, and also the type of form that we need to think about in the future. We need to make the different types of the form that should be the accessible for these applications. And then some of the rural area in the Myanmar they have some challenging, and then health literacy is really poor for them. They are not aware about the health screenings, and then subcare is not important aspects for them. So there is also one of the challenge for the communities. And then another thing is for the poor digital literacies among the older people is remain the challenge. So in the futures, we will need to be the address as we shift to do the more wider focus on the digital innovations, especially for the older people. And then we found out among these challenges, we also found out that another approach, like an intergenerational approach, is really helpful. In our community, we also found out that the younger generation is really want to be the help to the older people to use this digital application. So they want to help to their family member, especially the older people. So this is the one of the things that we can future wider approach for this application is the intergenerational approach. And then another challenging is that because of the situations and the challenging situation and the security issue, we cannot proper linkage with the healthcare centers when the application suggests go to the referral, go to the near healthcare centers, but we still need the proper linkage with the healthcare center. So this is one of the challenging for the applications. And then transportation difficulty is one of the main challenging. If we have a proper, if they have to go to the healthcare centers or the health facility, so they still have a challenging. Some of the area has transportation difficulties, some of the hilly region, and some other security issues. So this is one of the challenging that we face for the screening process for using this application. So, and then based on that, we also found out the achievement from our implementation time. So surely that application can be the assessing for the early assessing of the risk of NCDs and the mental health among our community members. And also the another is via this application, they can also assess the health educations, and then they can change their behaviors, and also that they can take off some of the health informations in their life. So this is the achievement that we got it. And for the scaling up and the sustainability, we plan to continue our self-care application with our existing programs and also the healthcare sector activities in the ISAG activities and the HelpAge also. And also we will continue to share this aggregated results and the learning with the community members. And also we plan to include and extend this application in the future programming designs, and also the way of another innovative approach for the digital approach in another future program designs, and then applying in the proposal or some kinds of the future work. We will integrated this digital innovative way. And for the expanding of application, we were trained to our CBO, CSO in using of this application. So this is all of the presentation. So if you have any questions of the some of the information you want to know, you can also reach out to this presenters. Yes, thank you so much for your kind attention. So I would like to hand over to the Poppy. Poppy, please.
Thanks, Dr. Khin. Thank you, Paing, and thank you, Professor Halloween, for those really thorough, speedy presentations. There's a lot of information contained there. Some really interesting things that I hope everyone appreciated. I've seen some good questions and some requests for more information filtering into the chat box. So that's a really good sign. I really appreciated learning more about the challenges from you. And the issue on engagement with the online learning, but also in terms of the application, the benefits of the intergenerational approach. I think there's lots of exciting avenues to explore with this. I think before we move on to the questions, I'd like to go over to our panel. We have some discussion areas there as well. So I'll begin by introducing our three panel members. So we have Professor Martin Rusnák from the University of Trnava in Slovakia. Professor Martin.
Hello.
Hi, Professor. Shall I continue to introduce you, or would you like to introduce yourself?
Yes, no, go ahead.
Okay. Didn't want to talk for you. So Professor Martin's primary expertise in public health is focused on health in all policies work, and he has a special interest in post-conflict situations. relevant to our conversation today, I think, and wide experience in evidence-based management of patients and clinical practice guideline development and implementation. And the core of his educational approach in the field of public health is mostly interactive and based on distance training approaches. So welcome, Martin. We also have Dr. Ombiro, who's a medical doctor and public health specialist currently working with Medtronic Labs, where he leads policy and research. And in his role, he supports the development and review of clinical workflows in their digital platform developed by Medtronic Labs called SPICE to ensure they are evidence-based and also aligned with the country-specific protocols where they work. And Oren has previously worked at the Kenyan Ministry of Health headquarters and in the non-profit space. And finally, but by no means least, we have Dr. Rana, who's the mission head for health and care at HelpAge India. And she's been working towards accessible, essential healthcare solutions for marginalized and older populations. And during COVID-19, was able to lead the team and necessary support to communities, including facilitating the delivery of the vaccine. Dr. Rana is a trained medical doctor, healthcare administrator with extensive experience, more than 2 decades working on non-communicable disease. And so with that completed, Dr. Rana, if it's okay, I'd like to go to you first, actually. So we've heard from Dr. Khin and Paing there, some great feedback from the field, but also some challenges for older people in accessing the digital tools and using them. So I wondered, in your opinion and experience, what are some of the potential barriers to adoption and use of digital tools, and particularly among applications, and if possible, how can they be overcome?
Yeah, thank you. And good morning and good afternoon to all. So particularly before understanding and talking about the tech solutions or the health solutions for the elderly, we must understand what are the issues with the elderly and their health. So basically, if we can divide into 3 categories, so the elderly face the physical problems due to the aging, and then the perceptual the problems which are visual or hearing, and third is the cognitive, and fourth is majorly the chronic diseases, what we call the non-communicable diseases like diabetes, hypertension, cardiovascular diseases, COPD, etc. So the importance of all these tech health solutions has actually gained importance during COVID-19, particularly for the elderly, because the elderly during this time were confined to their homes and were not able to access the healthcare solutions and were not able to reach out to get these healthcare services. So from our experience, we have done certain, would say the pilot projects on how can the healthcare solutions be made available or accessible to the older populations in India. But before that, I would also like to say here that there is a huge digital divide, particularly in the countries like in India. And we have seen that there has been a survey by the mobile ecosystem in 2019, and which said that the penetration of the mobile application particularly is very low in rural elderly, particularly in rural area and older population. And similar report has been reported by a survey done, which was a need assessment survey for the digital literacy done by HelpAge India in 2019 and 20, early 2019-20. And where we found that 60% of elderly, older population are not taking any digital health solutions because they do not have anyone who can teach them how to use that application. So this shows that how much is the digital divide. So talking about adapting the digital solution by the elderly, particularly in the countries like India, is really a challenge. We'll talk about the challenges later on, but what the HelpAge India has started doing some of the experiments, the pilot, and what we have learned so far. So there are particularly 3-4 areas I'll talk about. One is the telehealthcare solution. So we have started a telehealthcare solution mostly to reach out the remote areas where the accessibility of any healthcare provider is very low or abysmally low. So the solution was to do the assessment with the help of community health workers. So here, this is similar to somewhat similar to SUNI-SEA project, where the health worker assists the elderly to Bluetooth-enabled tech solutions like e-stethoscope or blood pressure monitor, and that solution, that equipment was connected to the tele software. So the community health worker would assess on the parameters, send the report through the software to the physician, and then the physician would make the judgment, the consultation, and provide the e-prescription. So this was the project which we initiated even before the COVID times to do in remote areas of Madhya Pradesh. And this was pretty successful. And we will be able to reach out more than 2,500 older population to this solution. But the thing was here that it would require the community health worker, because one, the elderly in the remote areas do not have that, even a small, simple Android phone, which is we see that everyone does have right now, but it is not, particularly in these kind of areas, right? Secondly, they do not know how to use it. So a support from the community healthcare was essential to use that. This was one example. Second example, we experienced during the COVID vaccination time. So we knew that there was a COVID app was identified and developed by the government of India to use register people for the COVID vaccination and to implement the COVID vaccination in the elderly. Particularly the elderly in the remote areas, they did have the access to that mobile application, the Android application to the COVID app. Second, there was a language barrier because the application was particularly developed, as we all developed in English language, but there was many dialects in the country. So they were not able to understand what to write and where to write. Third thing is it was very complicated for them. So as per the elderly, they need some big font size, a bigger screen, if they are able to use that. So there are certain challenges. So we did this again with the help of the volunteers. So we identified, the HelpAge India identified the volunteers from the community itself who could help the elderly to register on the app and facilitated the COVID vaccination. So with this support, the COVID vaccination facilitation, we could provide vaccination to nearly 9 lakh elderly during the COVID time. Third thing, again, COVID time pilot testing was the COVID SOS app. So this app was developed by some of the IITians, ex-IITians from Delhi. And this COVID app was particularly for the identify the volunteers and the elderly who were in need at that particular time for their basic needs as well. So through the helpline, what we used to do, HelpAge has a helpline application. So wherever through the helpline, whosoever used to call the helpline counselor informed the person to download the application, this COVID app, and through the COVID app, they could identify location and they could understand that what is the need of that particular elderly. Through this application, nearly 25,000 people were supported and 4,000 volunteered to support these elderly. So these are certain areas where we had some experiences how the digital application can be useful and can be adapted for the elderly, not only the healthcare solution, but also the other care solutions as well. So what I used to say that there is another example of how can we bring that that solution towards the community. So this is the digital literacy, what we used to say. So digital literacy is one of the programs which we tried and actually helped out many elderly to understand how to use the digital platform. So there was one project which was supported by the Google. It's still going on. So we started that digital literacy program, particularly for the safety program, for the financial security and safety in this particular project. So nearly 10,000 elderly were actually trained initially on the web platform, but later on during the physical or the community mobilization platforms where they used to come in a group, and the person can teach them how to use that. So the idea is that elderly can use if they are provided that training, if they are facilitated how to use the particular app. So when I was looking at the SUNI-SEA project and I was learning these experiences, so yes, the application can be used with a little modification, particularly for the rural elderly and with the support of the community health workers. The community health workers here is a catch, because in countries, developing countries like India, where everyone doesn't have that application, how can we benefit them? So these are certain examples. So now the self-care, if I talk about some of the self-care apps. So one of the self-care app was an app which was piloted using, which was introduced to the bed of the people at the home, old age homes. What this app used to do when you are lying on the bed, so this app could monitor the vitals of the person. So this was again piloted in 50 elderlies, and this could actually help us in making understanding any warning signs if they were able to. But again, how to use that? This is something which need to be taught to the person, and the confidence should be there that I can use this solution, and there is a referral system. So if we have these links, understanding, using, and then referral path, then it is a useful device. It can be used. So when I say the potential barriers, so you asked Poppy about what could the potential barriers and what would be the potential solutions for this digital or the healthcare solution. So barrier here I see is one is the digital knowledge, understanding, information. And second thing is the accessibility. So accessibility not only in the physical form of the device, but also the software understanding the application, and including the language, the screen size. So these are the potential barriers which I see any community, whether it is elderly or any other person, would have, particularly to use this kind of solution. How to overcome is, again, we should initiate many digital programs, digital literacy programs, either through the community workshops or in SUNI-SEA. And we have also used an intergenerational kind of training or learning programs. And also the peer-to-peer. Suppose one person in the society, or there are some groups, elder self-help groups in rural areas. We have developed these kind of groups. So one person has been trained, and the person is training to his or her peer groups. So these are certain areas which can promote the digital solutions across. This is what I want to say here. Thank you.
Thank you. No, that's really interesting. And I note that both yourself and Dr. Khin talked about kind of that peer-to-peer, and even I think both mentioned that intergenerational aspect, which I think sounds like it'd be really important. I think it also sounds like keeping in mind the user is really crucial when you're designing these tools as well. So Dr. Ombiro, with your experience in mind in terms of the various digital tools that Medtronic has developed, what are some other best practices, do you think, for designing and implementing digital health solutions?
Great, thank you very much, and congratulations to the SUNI-SEA project for the work that has been done so far. Quite impressive, and very interesting to see some of the parallels in the work that you do and in the work that we have also done, especially in Africa. So I'll share some of the experiences we've had and the experiences, some of the best practices that we've seen. And one of the things that I think is critical is having a lot of effort in identifying and defining the gap to be filled, and whether this is a true gap experienced by the user. So whether that's access to care or access to training or offering quality of care or clinical decision support. So what exactly is the gap to be filled, and ensure that the digital platform that is being deployed is actually filling a true gap as experienced by the user. So that's one. The second one is around co-creating the workflows and the content that is being deployed by the digital platform with the users. So this includes ensuring that the language or the questions being asked are actually culturally appropriate. They are easily understood by the users. So in some of our examples, we've had to translate into local languages like Swahili and pre-testing those questions with the users before deploying to ensure that they are actually understood as intended. They are not annoying to the user, and they are actually culturally appropriate. The other thing is around training and mentorship, and this has already been mentioned. So we have digital literacy issues depending on the geography where you are deploying the digital platform. So it's ensure that you appropriately train, and not just train, but do a lot of mentorship and follow up with the users, while reinforcing the value proposition of using the digital platform. So there is the usage of the digital platform, but the why are we using these digital platforms needs to be constantly reinforced as we do the trainings and mentorship. So in our experience, we do trainings, we do practical exercises during the trainings, we do follow-ups on day 3, at week 2, at month 1, and we also review the data that is coming out of the usage of the digital platforms, so that our mentorship efforts are targeted where we are seeing clustering of issues, for instance, while usage of the digital platform. And we also track implementation. So it's important to track implementation and gather real-time feedback from the users. And as you gather the feedback, quickly iterate based on that feedback so that the users feel heard. So the initial days of deploying a digital platform, there are usually many issues. So it's good that the iteration and the changes to the digital platform workflows are real-time, so that the users feel that their work and their feedback is being heard. And then finally, it's important to monitor and evaluate the intended outputs and outcomes. And this includes the clinical outcomes as well as the patient-reported outcomes, being generated through the digital platform, and ensuring that all these data and all these insights are fed back to the users so that they see the utility of their work and the utility of utilizing these digital platforms. So this is what we've been able to do. And we believe these are some of the best practices to ensure that the digital platforms that we deploy are actually adopted by the users, and they serve the intended purpose, and they produce the intended outputs and outcomes. Thank you.
Thank you so much. That's really interesting. I really liked, you said co-creating workflow and digital platforms. And I think where possible, having that feedback from, for example, in Myanmar, the older people and the volunteers particularly, about how it's used will be really helpful with looking at how we develop it going forward. I'm quite conscious of the time for the panel speakers, and we haven't yet had much of an opportunity to touch on the online learning and education side of things. But I do think that point about co-creating the digital platform is interesting. But Professor Rusnák, I wondered, HelpAge has just piloted this platform, but we have a long way to go in terms of rollout. And with your extensive experience in continued professional development and digital tools, what would be your advice to the Myanmar team or others on this call about how online learning tools can effectively bridge a gap? And can they effectively bridge a gap in these sorts of scenarios?
Thank you very much for this question, and also for a very interesting webinar. I've been with HelpAge already for how many? 3 years almost, right? And a part of my involvement was also in developing this distance learning tool, contents, giving some advices. All of that I built on my experience as a teacher of public health and a former medical doctor with some experiences in medical informatics. And first, I would like to congratulate on the achievements, but I also want to look at the future, because the program is going unfortunately towards the end in a month, and I think we should also think about continuing our collaboration. There is a good opportunity from the side of the European Union, which offers a so-called global health strategy in changing world, which is a program or a policy document. And this document directly speaks about foster digitalizations as a fundamental enabler of health, which is one of the tools which might be used to continue. From my side, I would offer my university and the education which we provide remotely in English, and this is a Master of Public Health program which is oriented to healthcare workers which already possess a magister degree in the fields of health sciences, and that program is 2 years long, and MPH is accredited by the EU accreditation process. We also offer a PhD program for those who want to go into the research. And this field we are talking about requires a lot of research. We are in the very beginning of the whole process of researching what are the best approaches in using digital technologies. There are new fields which are currently being offered. I have one of these variables which I control my pulse and ECG from time to time. There are new devices which measure blood sugar. So this is a totally new field combined with artificial intelligence, which is now kind of a new thing. So there is a lot to learn about opportunities and to do a lot of research together. And for me and my colleagues, as you already met, Dominika, Julka, and others, we can promise to you that we'll be instrumental in supporting your colleagues, your students in either MPH program, or if you decided to go for the PhD education. So that's what I wanted to share with you, and please let me know your thoughts, and just write directly to me or through Poppy and the colleagues. We already have connections. Thank you very much. Really nice webinar. I'm very happy to be here. Thanks.
Thank you, Martin. That's a really exciting offer, and I'm sure there's lots of people from the HelpAge Myanmar team on the call who'll be really pleased to hear that, and will, I'm sure, be in touch and tapping your brain for any more knowledge as they continue to develop their work there as well. I think without trying too hard, it seemed we've been very good at keeping to time. We're exactly on schedule for some Q&A, which is always great. So there has been some in the box, which Tim's always kindly consolidated for me. And we'll move on to those now. Okay, so the first one is for Dr. Khin. And Sarah has asked, thank you so much for your presentation. I think Sarah's actually left now, but she can listen to the rest of the recording. Thank you so much for your presentation. Just a question on the questionnaire. Was it filled out by older people's associations or independently by people themselves? Were there any challenges experienced by older people accessing the application? Oh, perfect timing. Oh, there you are. Are you there, Dr. Khin? You're on mute.
Sorry. Yeah, sorry for that. Yeah, sorry. Yeah, my connection is lost for a while. So can you hear me?
Yep, can hear you.
Yeah. Okay, yeah. Yes, yes. So let me reply for the questions of the Sarah, right? So for that one is yes, for she asked about is there any pay out by the Older People Federation that is the independently by the older people or not, right? So for the question, yes, for the Older People Federation that was mainly founded with the older people and also the management teams, and also for the activity also only led by the older people. Yes. So and then there was also representative for the whole country level. There will be the different townships and the different all over the country. They have a representative for the older people. So yes, surely they are the independent associations that was found with the older people. Yeah.
Oh, and sorry. I think Sarah's question was more about whether the older people themselves filled in the application or whether they were supported by the association. So that in Myanmar it would have been the inclusive self-help groups. So I suppose she's asking about the challenges that older people had in actually using the application itself.
Yes, yes. Thank you, Bobby. Yes, sure. When they use this digital application, they face many challenges. So we also need to think about these kinds of the challenging, such as the internet and also the mobile phone, digital literacy. And so for the our approach is that we have volunteers. We train the volunteers. So volunteers help the older people to install the applications, and then sometimes even they didn't difficulty to read, and then they cannot even see some of the like the font size. So the volunteers help them to read the questions on behalf of them, and then they will fill out their information. And also the physical measurement assessment, also our volunteers supposed to check in this kinds of the physical measurements and put it in the applications and then find out the risk factor. So this is the one way we supposed to the older people, and the another way is the intergenerational, as I mentioned in the presentations. And we also encourage the around their family members. They also like the younger generations there. So we for example, in the one family, younger generation have a mobile phone. So we encourage to install these applications, and then knowledge about self-care applications, and they give to the younger generations. And also they also willing to have their family members, older people, to get to know about the risk of their family members. So they encourage to use this application with the help of the younger generation. So it kinds of the intergenerational approach that help each others like this kinds of things. So that we face during this period. Yeah, sure, older people have a lot of challenges. So but we don't left behind them. So we encourage to use this application by using this kinds of the way to include all older people included. This kinds of way we did it during our implementation time. Yeah, thank you.
Okay. That's great. Thanks. Sounds similar in terms of challenges, but also approaches that Dr. Rana faced and HelpAge India as well. And also sounds like, you know, perhaps there's lots of use as well in looking at kind of like the healthcare patient provider connection. In Myanmar, we had to focus more on self-care, but perhaps people difficulties using these tools, that's the way we would move. So just I'm aware of time, so I'll keep going through the questions. So Diana has said it's very useful work, thank you. Is there any data collected on associated complications on the NCDs, e.g. cataracts or strokes?
Yes. Yeah, for the data collections, as you know, this is the self-care application. So we are not, this application is not the kinds of the data collection tools. So we also include in the questionnaire, like if the participants have the previous histories of the hypertension, of the diabetes, and is there any others complications there or something kinds of the information if they have they can put it. So and then such a kinds of that application is a self-care application. So we are not too much data gathering. So sincerely say, like the get rest or the stroke, we didn't have exact numbers of the data in the application, but they have if they have a complication, they can fill it out for their self-care and the self-assessments of their risk, some kinds of the things. Yeah.
Okay.
Hope this answer will be helpful.
I'm sure it will be helpful. Yeah. There's a lot flying in for you, Dr. Khin. Arthur from Uganda has asked whether the work's already published. He's interested in adapting it here, so we can, I'm sure, send him over the reports and things. And I don't know if he's still online, but Arthur, we can send over lots of materials afterwards, I think.
Yeah, at least our application is in the Google Play Store, so I think all of you can check from the Google Play Store and then learn from this application. Thanks.
Rose has asked a really interesting question here. And it could go to one of the panel or someone at HelpAge. So as highlighted in the challenges, using the digital approach for older people, did you encounter challenges in digital learning, age-friendly design of the digital application for those who connect digitally? Do not think it's essential to continue to access health services in person. Dr. Rana, do you have anything you'd like to contribute in the accessing health services in person, and whether, yeah.
Accessing health services in person, it is difficult for a person to use the application himself or herself, but the person, if assisted, can use that. Suppose that's what we have encountered during our telehealth project, that it has to be the person has to be accompanied or assisted by a volunteer or a community health worker. Then it is easy for the older person to access that healthcare solution. It is very difficult, and it is this particular application would enable to do the preliminary screening, which will reduce the travel cost, the time, also the cost of visiting physically to the physician. So this application is useful, but has to be assisted for the elderly, particularly by through a community health worker or a volunteer or a family volunteer. It could be from any of that.
Yeah, no, that's really interesting. And I think we tried to kind of, in Myanmar, we weren't trying to replace, but certainly in places where services and so on are really scarce, if they're, like you say, if those pieces you can do, checking for risk factors, some screening at home, and save on the transport and those other things. But I think everywhere in the world, people, I can't see digital tools completely removing like in-person interactions. I think they're really useful, and I hope that we can continue to grow and benefit from them. But I hope it doesn't mean that we don't ever speak to a person in real life ever again either. So there's some of the questions are more like just more interest. So Sanju from Aging Nepal has said that the application looks very useful, particularly for developing countries like Nepal, where older people are unaware about their health status and they have to travel hours even for simple health checkups. I'm very interested to know more. So I think that kind of speaks to that point again, sometimes it's about delivered in the home, whether that be by volunteers or people themselves, and how that then connects into more formal health service provision. Question on the project. So for you, I think, Dr. Khin, Rose has asked, what was the sample size? Did you give the mobile phones for free? If not, how was accessibility for older women, particularly for the digital application? And did you encounter ageism in the project implementation? Quite a big, quite a few questions there.
Yeah. Yes. Sample size. First is the sample size. Actually, this is not this application, the subcare, and also uploaded for the general people in the Play Store. So everybody can use and they can download the application. So we are not specific like target for the sample size. Only this population should use or such a kinds of the limitations and the target sample size. We are not setting out yet. Yes, because of this is a subcare application. So everybody can install and then use. But this is the NCD focus. So NCD is common into the older people. So we are promote our application among the older people federations or such a kinds of the inclusive suffer group, this kinds of the population we are promoted our subcare application. So, and then for this application is not only for the older people, but also we also included the mental health part that was for the younger generation also, less than 16 years old. They can also assess for the depressions risk and also the anxiety risk. So this kinds of the mental health risk also can assess from this application. So yes, for answering the question, we are not the specific target and the limited the sample size for the general. So up to now, we are continuously monitoring the servers and the data. So according to my presentation, in some of the slides, I just display like the the data, some of the data. We have some amounts of the users and the screening people. We have some data. So the data sample size is not be the limited. It should be the more in the future also. So yeah, this is the answer for the first one. For the another is thinking about the ageism at the beginnings of the project or something. We should think about this ageism. But for the situations, and we adapted the changing depending on the situations. So we have transition periods for this. So we adapted our project activities into the digital approach from the in-person. So we need to be the think about in the future for the based on the target population, we need to think about for the older people, like thinking about them, like the voiceovers in the applications, for the questionnaire, for the more friendly use for the older people, and also for the big screen at the big font size, and then also some kinds of the assistants using, and then for more friendly use of this application for the older people. So that should be think about in the future programs and the projects that was more innovative for the older people. So I hope this is okay for the answer question. Yeah.
Thank you. Yeah, I think there's other stuff out there as well, isn't there? You know, with like the voice over, like you mentioned, and more visual approaches too. But the payoffs are always are the mobile phones sufficiently savvy enough to manage those kind of things and so on. So I think getting the balance right seems to be important. Our next question is from Sanju. Again, can we use the mobile phone with application for many older people? Is Sanju still online? Sanju,
Yes, I'm here.
Yeah, can you clarify what you mean there?
Okay, actually, I'm confused that if I install an application in my mobile phone, and am I able to use that application for many older people, like more than not only from my home or an older person, but many, like our government has a policy to start or to formulate a daycare center in each municipality or ward of a municipality. So I think it will be useful for the group. So if we facilitate or we give training to digital literacy or digital technology friendly facilitator from that group, that person can be use that application for the older people of that group. So in that sense, I asked that question.
Yes. Thank you, Sanju. Yeah. Yes, you are. This is the subcare application. So for the if we install the application, you can create your own username and the password, and for your account, and the accessing by answering the questions and all of the information, put it and then find out the results for each individual aspects. But if we use the one mobile device, you have to log out from the first user. And then you have to remember your username and the password for the first individual informations. And then if you have moved into the another informations, and then to check the risk of their risk levels, you can create a new account.
Okay.
Yeah, new account, and then checking and then getting the risk, and then sign out again. So it kinds of the individualized and then assessment. So yeah, this kinds of the approach in this application. Yeah, thank you.
Okay, thank you.
Yeah, so I think in Myanmar, some of the volunteers would have a number of accounts or log in, or older people would log in on the volunteers' phone for a number of people. So it might well work in the scenario you're suggesting, Sanju, which sounds really exciting. I hope we can connect in on what you're doing there and share some more on the application. I think that question links to Trang's question, which is, she saw the username and password in the self-care app. So can people register for their own accounts, or do you provide the accounts? People can register for their own accounts, can't they?
Yeah, people can register, by their own accounts. Yeah.
And Sangeeta from India would like the presentations, and Arthur would like the link to the application. I think C has popped the link in the chat box, but after this meeting, for everybody who's registered, we will send round all the presentations, the links to the mobile application, and the contact details of the presenters, and anything else that we've promised to share in the last hour and a half. Are there any other questions? I think that's all the questions from the chat box, and we have exactly 1 minute left. So if there aren't any other questions, then I would just like to say on the whole screen. I would just like to say thank you very, very much to all our presenters, to the panelists who put in all that extra time to come and join us today and to share our learning. I feel like we could have talked for an extra couple of hours, but I'm very grateful for the time that has been shared. And I'm very grateful for the attendees. I hope that you found all the presentations interesting, that we answered your questions sufficiently, and that you can follow up with us if you have any more questions or just want to connect on the work that the team in Myanmar are doing. And thank you to Tenzo for moderating the chat, for C for organising us, and for Mary for taking some notes.